Beginning the examination by assessing the temporomandibular joint. Place the tip of your finger in front of the tongue of each ear. Ask the patient to open and close his mouth. Your fingertips should drop into the joint space as the mouth opens. Check for a smooth range of motion, feel for swelling, and then note any tenderness or caprice. Palpate the muscles of mastication, the temporal muscles, the pterygoid muscles, and the mastoid. Ask the patient to demonstrate protrusion and the retraction by jetting the mandible forward and the lateral and side-to-side motion. When he measures the shoulder, identify the following landmark and attributes. The bone structure of the shoulder include the humerus, the clavicle, and the scapula. There are three different joint articulation: the shoulder, the glenomerular joint, the sternoclavicular joint, and the oreoclavicular joint. Each group of muscles attach the shoulder. The scapulohumeral group includes the important sits muscles or the rotator cuff, supraspinatus, infraspinatus, and teres minor, and subscapularis muscle. Beginning by inspecting the shoulder and shoulder girdle and the scapular and lateral muscles posteriorly. During both inspection, note any swelling, discomfort in muscles, find tremor of the muscles. Palpate for tenderness at the sternoclavicular joint, tracing the clavicular laterally with the finger. From behind, follow the bony spine of the scapula laterally and upward until it becomes the summit of the shoulder. From the palpate and acroclavicular joint, and from there down to the coracoid process of the scapula. Palpate the greater cervical and the biceps tendon in the interbuccal group. Checking for the tenderness, also lift the humerus posteriorly so you can over the subacromial viscera and subclavicular viscera and the underlying sits muscles, which include supraspinatus, infraspinatus, teres minor, and subscapularis. Evaluate the range of motion of the shoulder. Ask the patient to perform the fixed motion of the shoulder cradle. These include flexation, where the patient tries his arm in front of the overhead, extension, where moves his hand behind, adduction, raising his arm out the side up and overhead, adduction, crossing an arm in front of his body, internal rotation, placing the hand behind his back to touch his shoulder blade, and external rotation, rotating and upward toward ceiling from shoulder level. If you suspect a problem, cup your hand out over the patient's shoulder and feel for caprice as the patient repeat this movement. The position of the hand in motion to see if movement is natural when fingers are relaxed. They should be slightly flexed. Inspect the patient's wrist and hand, nothing in any swelling over the joint as well as any deconformity. Observe the contours of the palm, normally thinner and hypothinner. Eminence is not any thickening of the tendon or fingers. Palpate the distal radius and ulna, the lateral and medial surface of the wrist. Palpate the radial styloid bone and the anatomically snuff box, a hollow depression just distal to the radial styloid process. Pain when palpating the snuff box suggests scaphoid fracture. Palpate over the 8 carpal bone, then distal on the wrist joint, and then each metacarpus phalangeal joint. Compress the MCP joint by squeezing the hand from each side between the thumb and fingers. Not any tenderness, swelling, or bugginess. Now, palpate the medial and lateral aspect of each of the proximal interphalangeal joint between the thumb and index finger. Not any swelling, bugginess, bony enlargements, or tenderness. Bony nodules on the PYPY joint or Burkhardt knots are common in osteoarthritis. They are beginning using the same technique examination the DIP joint and the 9-bone nodule at the DIP joint are regarding node as also common in the osteoarthritis. Repeat the other hand. To check range of motion of the wrist and hands, begin with the flexion and extension. Continue to assess the range of wrist movement with extension and abduction. If there are bands of wrist pain, suggest carpal tunnel syndrome test. Test sensation by assessing the medial nerve in the pulp of the index finger, the ulnar nerve in the pulp of the fifth finger, and the radial nerve in the dorsal web space of the thumb and index finger.
Hold it. Hold it. Hold it. Press. Okay, pause.
Examination of the spine by observing the patient's posture, including the position of the neck and trunk. Assess the patient for erect position of the head, neck, and back. Drape or gown the patient to expose the entire back. If possible, the patient should be in a natural standing position, with feet together and arms at the side. Processes, paravertebral muscles, iliac crests, and posterior superior iliac spines, usually marked by skin dimples. Next, palpate the spinous processes of each vertebra for tenderness. In the neck, palpate the facet joints that lie between the cervical vertebrae. Palpate the sacroiliac joint, often identified by the dimple. And inspect and palpate the paravertebral muscles for tenderness and spasm. With the patient lying on one side with one leg extended and the upper leg with the hip flexed, palpate the sciatic nerve, the largest nerve in the body. It lies midway between the greater trochanteric deformities, swelling, or abnormal posture. Then palpate the spinous processes of the cervical spine, as well as the trapezius muscles and the muscles between the scapulae. Identify any areas of tenderness. Now test range of motion of the cervical spine. To test flexion, have the patient touch his chin to his chest. To assess for extension, ask the patient to tilt his head back. Note any limitations in range of motion. To check rotation, have him turn his chin to his right shoulder, then to his left shoulder. For lateral bending, ask him to bend his head toward his right shoulder and toward his left shoulder. Next, for range of motion of the lower spine, begin with flexion. Curvature of the spine or unequal heights of the shoulders suggest scoliosis. Then move on to extension. The next maneuver is rotation. To assess lateral bending, have the patient bend to his right and then to his left. Pain or tenderness with these maneuvers warrants additional neurologic testing. For examination of the hips, let's review the pertinent anatomy. The hip joint lies deep to the inguinal ligament. Because of its overlying muscles and location deep, begins with careful observation of the two phases of the patient's gait. Stance, when the foot is on the ground and bears weight, and swing, when the foot moves forward and does not bear weight. Normal gait has a smooth, continuous rhythm. In including the iliac crest at the upper margin of the pelvis at the level of L4. From there, you can follow the downward anterior curve to level. With the patient lying on the side and the upper hip flexed, palpate the trochanteric bursa, lying over the greater trochanter, and the ischio-gluteal bursa over the ischial tuberosity, which is not palpable unless inflamed. Now assess the mobility of the patient's hips. First, check flexion. With the patient supine, place your hand under the patient's lumbar spine. Ask the patient to bend a knee up to the chest and firmly against the abdomen. Note when the back touches your hand, indicating normal flattening of the lumbar lordosis. Further flexion must arise from the hip joint itself. Observe the degree of flexion at the hip and knee. Normally, the anterior portion of the thigh can almost touch the chest wall. Note whether the opposite thigh remains fully extended, resting on the table. If the opposite thigh flexes, there may be a flexion deformity of the hip. Check extension. Have the patient hyperextend the thigh in a posterior direction. Check abduction next. Stabilize the pelvis by pressing down on the opposite anterior superior iliac spine with one hand. With the other hand, grasp the ankle and abduct the extended leg until you feel the iliac spine move. This movement marks the limit of hip abduction. Next, check adduction. With one hand on the patient's opposite hip, hold one ankle and move the leg medially across the body and over the opposite extremity. Test internal and external rotation of the hip. When this helpful test is normal, hip arthritis is less likely. Flex the leg to 90 degrees at the knee. Then stabilize the thigh with one hand and grasp the ankle with the other. Now swing the lower leg medially for external rotation at the hip and laterally for internal rotation. Repeat each of these maneuvers on the opposite side. The examining table, and with his knees in flexion, inspect the knees, noting their alignment and any deformities. Note loss of the normal hollows of the patella or atrophy of the quadriceps muscles.
पॉज किया था नहीं
Then, straighten the patient's leg and palpate the suprapatellar pouch on each side of the quadriceps, noting any swelling.
पॉज
Palpate the tibiofemoral joint, the edge of the tibial plateau, and the margins of the joint. Note any irregular bony ridges.
movement like this
Palpate the medial meniscus. Then palpate
Next
the lateral meniscus. Tenderness suggests a partial tear. With the knee flexed 90 degrees, assess the medial joint compartments for any tenderness. Palpate the medial femoral condyle, the adductor tubercle, and the medial tibial plateau. Also palpate and identify the medial collateral ligament. Assess the lateral joint compartment and palpate the lateral femoral condyle, the lateral tibial plateau, and the lateral collateral ligament. Assess the range of motion of each knee beginning with flexion and extension. Be sure to provide support as needed. Check internal and external rotation of the knee. Instruct the sitting patient to swing the lower leg toward the midline and away from the midline. You have already palpated the menisci for tenderness, 2 of the 7 major structures of the knee joint. To test the medial collateral ligament, or MCL, perform the abduction or valgus stress test, where you move the thigh about 30 degrees laterally to the side of the examination table, push medially against the knee, and pull laterally at the ankle to open the knee joint on the medial side. Injury lateral side. If it slides forward, where you push the tibia posteriorly and observe the degree of backward movement on the femur. Now ask the patient to extend the leg to check the integrity of the patellar tendon. Inspect the patient's ankles and feet. Note any deformities, nodules, swelling, corns, or calluses. With your thumbs, palpate the anterior aspect of each ankle joint, noting any bogginess, swelling, or tenderness. Feel along the Achilles tendon for nodules and tenderness. Palpate the heel, especially the posterior and inferior calcaneus, for tenderness. Palpate the plantar fascia as well.
दोनों पैरों next leg.
Palpate over the medial and lateral malleolus, especially in cases of trauma. Compress the forefoot and the metatarsophalangeal joints for tenderness. Palpate the heads of the 5 metatarsals and the grooves between them.